I think, yes.
Yeah, on
So
the
this is
second
rhythmic, bradycardic, and you do
pericardic
see P waves, okay?
P waves. And
Hmm.
after that, I need to see what was it again?
Next one, the
Mm.
morphology of the P wave.
It's, oh, okay. Morphology. It's very flat.
Okay, there is no need to say flat or something. First of all, you have to concentrate the duration of the P. Okay,
Okay,
this is one. That's the first one. Next
okay,
one, the height on a P. Okay,
okay.
and the
So,
shape of the P. So
okay.
based on the duration, if it's relatively less than zero point
Then,
0.1 second, is okay. All right, this is one.
mm,
Next one, the high. If the
it's
high is bigger or equal, okay, I tried to draw it, 2.5 millimeters, that means tall, okay?
mm,
So it's meaning that's tall, all right? And the shape, as we said, okay, if it's
okay,
bumped, that's meaning something to us,
mhm,
and that could indicate this was, for example, the right atrial hypertrophy, and this is the left atrial hypertrophy. And if you
okay,
have wide and tall, that means biatrial hypertrophy. Okay? This is the
okay.
shape. You don't need to talk too much about the shape. It should be round shape, of course, but this is too teeny tiny, as you said. But the best one, if you look at, for example, V1, is a biphasic one and looks like both the initial and the terminal phase the same. So there is no atrial hypertrophy. Okay? This is what we had it so far.
Okay.
Next one that you have to look at, which is the next one,
PR
PR interval. Okay,
interval.
that looks like, okay, let's see when we do have, okay, I think that one. Okay, this is the end of the QRS, and this
Mhm.
is the beginning of the P wave.
Yes.
So that indicates here as well, you can see very nicely in V1, for example, that you do have bigger than zero
Zero point
point
two
0.2.
two
Okay,
seconds.
all
Yes.
right. Meaning,
Um, Longer PR
uh-huh.
means, oh, what was it? Mm, it's the pre. Mm,
Okay, every P followed by QRS complex. When we evaluating the connection between P wave and QRS, we are evaluating the conduction in the AV junction. Yes.
Okay.
So if it's elongated, but every P followed by QRS, that means first degree, all right?
Oh, yes.
AV block.
Yes.
If not every P followed, but you do have a rhythmically produced P wave, but not every time is followed by QRS, that's the second degree. All right, this is, we are evaluating the AV blocks here. Or if it's
Mm,
short, the pre-excitation syndrome. All right? So
okay.
here we do have a little bit elongated PR interval, but every P followed by QRS. So that's meaning we do have a
First block,
first degree of
first
AV block.
degree AV block
Okay, good. Next one,
is a
QRS
QRS
complex. Is it
complex.
wide
Seems
or narrow? This is the question.
it looks narrow, so
Okay,
I think it's
good.
normal.
All right. Next
And
one, the axis.
axis, the lead one is positive, and AVF is also positive, so it's a
So
normal degree.
normal. And if you are comparing the size of the QRSs, you do see that 2 is the biggest
Two
one
is
and
bigger.
a little bit maybe in lead number 1. So I would say
So
about maybe 50 or so. Okay.
can I also say since the AVL looks equiphasic, so it's 60
Well, a little
degrees?
bit, I think is positive.
Okay,
But if you say that, okay, it doesn't matter, it's depending on you. If you said that AVL is equiphasic, this is why you say that that should be 60. Okay,
okay,
immediately. You can say it.
okay.
is depending on how fast you say it and how, I mean, you are sure for what you are saying, that is true, that's the meaning. Okay, good. So we do have a normal axis for sure. All right, go on. Next one. Inside the QRS. We do not have intraventricular conduction abnormality because it's not wider. But there are two different parts that we can say about the bundle branch blocks. First of all, if it's not wider, it's in a normal range, but you do see the special picture. For example, in V1, you do see this RSR complex. You still can talk about the incomplete right bundle branch block. And if you do see some, for example, QS complexes in V1, V2, V3, and you do see a nudged QRS, for example, but still within the normal range, you can say that's an incomplete left bundle branch block. But if it's wide, for sure you have right or left bundle branch block is a complete, as we said. Okay, but there is no, okay, in this situation. Go on.
Um, and I can see
Next
in,
one, still inside the QRS, still inside the QRS.
yes, in V1, V2, and V3, there
What?
is in V1, V2, and V3, I can see um a very deep S wave.
Okay, that's okay, that's okay. Before we look at the size of the QRSs, we should go for the pathological Q wave, okay?
Okay.
That's important because very, very important. It's more important than hypertrophy. If somebody has MI, that's a critical one. Hypertrophy is okay. That's a chronic situation.
Okay.
So is there any Q?
I
No,
don't see.
no,
I don't
no,
see.
no, no. Yeah, AVR, but who cares about AVR? It doesn't mean anything because it's looking inside the chamber. We do see, however, in lead V2, V3, V4, basically we do not have it. So and only one lead doesn't mean anything. So there is no. Okay, we can say no Q wave. Good.
Okay.
Now you can go for the hypertrophy and you can compare the size. I show you this should be the end, okay, the end of the R wave in V5. Look at here, okay. So this is the all is the R wave in V5,
Mhm.
and this is the S wave in V1. And the voltage criteria, if you summarize these two, if it's bigger than or equal than 35 millimeters, you can say this is a
Left ventricle
left
hypertrophy.
ventricular hypertrophy. Very good. And another thing that you do see here, I'm happy that I can show you, these kind of STT changes that occurring right here, and that is called a strain. That is accompanied by ventricular hypertrophies. Okay?
Okay. Wait, so if you said if it's more than 35
Five,
milli,
yes.
so it will become hypertrophy, right?
Yeah, but itself, if V5 is bigger than 25 millimeters, again, that can mean this is another voltage criteria for hypertrophy, left ventricular hypertrophy. Or
Okay, so
if you are
it's
looking at lead number two, again, if it's bigger than 10 millimeters, again, okay?
okay. Thank you.
These are the voltage criteria because ECG is not the best to diagnose hypertrophy, but there are some cases when you can do it. Okay. All right. So first degree AV block and the left ventricular hypertrophy. This is what we had in the skin. Okay, good. Now let's see. Let's see which one that I should. All right. Left ventricle, left ventricle, left ventricle, left ventricles. I'm going to the. Okay, let's have an easy beasy one. Okay. Uh, Yayung, Yuyung, or
Yes.
okay, much easier to say park.
Oh, Jiang, it's Jiang. Which number should I,
102.
or 102?
Mm-hmm.
Or didn't we just do 102 though?
Pardon me?
Didn't we just do 101, 102?
Oh, I'm sorry, 107. Ah, Jesus, yes, you are right. Because I'm looking at my iPad, which one should be the next one. And yes, 107. I'm sorry.
Okay. 107. Okay, it looks rhythmic to me,
Mhm.
and there's a bit less than three boxes between the
Rhythmicity, heart rate.
so it's rhythmic,
Mhm.
and heart rate is it's around wait, sorry, it's three boxes, so around 100 beats per
Mhm.
minute.
Okay, good.
A bit slightly tachycardic.
Tachycardic, period.
Uh,
Okay.
and P waves, there are P waves when you look at lead one.
Mhm.
So P waves are visible. What else? The QRS complex looks normal, I think.
Mhm.
And the axis, sorry, just a moment. Axis, lead one is positive. Sorry, wait. Lead one is positive and AVL is positive. So it's in the normal axis.
Uh, lead number one is positive. It's okay. AVF is negative. For
Oh,
sure is
AVF,
not
sorry.
normal.
Sorry, AVF is negative. Sorry.
Yeah, lead number two is negative as well. So for sure is not normal because it's meaning that is less than minus 30. So it has to be an extreme left deviation. AVR is negative, so it's meaning that the axis is between minus 60 and minus 30. So that meaning we do have as extreme left deviation. Okay, go on.
Okay. What else? The QRS duration.
Next one, the morphology of the P wave, PR interval.
Morphology of P wave. PR. Okay.
Okay,
mm,
lead number two. The width of the P is okay.
mhm.
The amplitude is not bigger than 2.5. So that's fine. All right. Next one, PR interval. Is less than 0.2, so that's normal. Okay? Are you here?
Yes, yes. I
Okay,
sorry,
so it's
noting it down.
normal. Okay,
Yes.
there is no
Mhm.
AV block. Next one, the QRS complex, narrow or wide?
Narrow.
Good. So there is no intraventricular conduction abnormality, bundle branch block, right or left. As I said before, it could be, but by looking at only the shape of the V1, oh, it's not. Okay, go on. But so far you had an extreme left deviation. What do you think? What could be the cause of this left deviation?
Um, yeah, I'm not sure.
Yeah, what can cause extreme left deviation? There are some things, such as left ventricular hypertrophy, but you do see a sign that the big R in V5, V6. No. Next one, inferior myocardial MI, pathological Q wave, 2, 3 AVF. This is why you have an extreme left deviation. But you do have an initial R, so it cannot be MI, inferior MI. Next one, WPW syndrome, when you do have a short PR interval. You don't have a short PR interval, so it's not WPW syndrome. Next one. What else can be? Left bundle branch block. Okay, but you don't have left bundle branch block because QRS is not wide, and you do not have any nudged R wave in V5, V6 or lead number 1. Whatever is left, left anterior hemiblock, because hemiblock is not going to elongate the QRS, all right? But only the axis deviation that occur here. Capish?
Yes.
Practicing.
Yes.
Okay, Milos, are you here or on the way home?
I'm here now.
Okay, great. Great. Okay, so this way I give you a good one. And a good one. Yes, I think 109. And this is 109. No, it's 1011. That's 109. It's yours.
Okay. So, arrhythmia, first of all,
Mhm.
the heart rate around 75 around normal.
It's okay. It's a little bit less than 75. Yeah, because it's 1, 2, 3, 4, almost 5, so it's close to 60.
Okay. Yeah, you have P waves.
Yeah, we do have P waves in lead number 2, positive, and in AVR looks like this is a negative.
Mm-hmm.
So
So it's a sinus rhythm.
yes, that can be sinus. But you said this is arrhythmic. Why is
Yeah.
it arrhythmic?
Because of the distance. Yeah, the distance between the beats 2 and 3
Okay, so we
is
do
shorter.
have an abnormal early coming beat. This is called, what would you say
Um,
about this beat?
an extrasystole.
Okay, that's a premature beat, an exosystole. And what is the origin of this exosystole?
SA.
What? If you had a premature beat that coming from the assay, first of all, you should see a similar P wave in front of the QRS. The QRS, PR interval should be the same. QRS should be the same as before. And this QRS is same than this one.
No.
So is it wide and negative the T wave?
Yes.
So
So ventricular.
premature ventricular contraction. Yes. Okay.
Yeah.
Now, by looking at whether this premature beat is completely compensated or not, what you should do, basically measure this distance, okay? All right, this
Mm-hmm.
distance, and compare to this one.
Yeah. So it's the same.
Exactly. So that's a compensated. And you know that ventricular premature beat always compensated unless you have some problem. Okay?
Okay.
Next one.
Well, the axis.
Nope, nope, nope. P wave first. Step by step. This is I was reading the letter. I giving you a guide. Okay.
Okay.
The P wave, the morphology and the width of the P wave. This is normal
No.
because it's
There's
wide.
two.
It's
Yeah.
wide and
Has 2 bumps.
notched. What does it mean?
There's some sort of atrial like enlargement.
Which atrium enlarged?
The left.
Exactly. This is P mitrale or left atrial enlargement. Good. All right, go on. Next one. What is the next one?
Pathological Q waves.
No, no. PR interval step by step.
Okay.
PR interval.
It's widened.
But every P followed, except when you do have this PVC. So that meaning,
That there's no AV block.
yeah, there is a AV block because PR is wider, is longer.
Oh,
Huh?
but if it's followed, if it's, oh, right, I see. Yeah, okay. So then it would be a second degree AV block.
First degree. Look,
But the,
first degree means every P followed by QRS. Okay? Look at this portion.
but
Yes, this
except
is
for the
so.
other one, right?
Yeah, but that's a premature bit.
Right.
And by looking at the normal part of the ECG, you can see that, yes, in everywhere when you do have this P followed by QRSs, the PR is longer. So this patient does have a first degree AV block and had only one PVC here. That's okay. It still can be normal. But
Mhm.
this longer PR cannot be. So this is why this patient does have a first degree AV block. Okay,
Okay.
go on.
So now
Now you can go
pathological
for the
Q.
QRS.
Okay. I don't really see any pathological Q waves. Uh,
Width of the QRS.
Width of the QRS is generally narrow, except for the extrasystole.
I do not think that's no, it's narrow. See, that looks like wider. Okay, I would say that this QRS is wider than normal. And here as well, you can see in V1, for example. See,
Yeah.
it's wide. It's
Okay.
not narrow. Okay, what does it mean?
Ventricular conduction error.
Exactly, intraventricular conduction problem. All right, now you have to look at V1 and V6 or lead number 1, but you can compare this one too. So whenever you do see the nudged R wave, the block is there. V1 is a right side, lead number 1 is a left side, and V6 is a left side as well. So
I'm not sure. All right.
that's a QS complex, and that's a nudged R. Now, what kind of bundle branch block we have? Anybody can help him.
Left.
Left. That's a left bundle branch block. Okay, great. Now you can go for pathological or axis. First of all, the axis. Let's see the axis.
Okay. Positive lead 1, negative AVF, and negative lead 2.
And
So you would
equiphasic in
tell,
AVR.
yeah, so extreme left axis deviation.
Yes. What does it mean? What caused this pathological left deviation?
The left bundle branch block.
Correct. Very good. Very good. Next one, you deal with the pathological Q wave and hypertrophies, okay?
Okay. Yeah, so I didn't see any pathological Q waves. So I don't think there's any
Okay.
hypertrophy. Oh, sorry, am I?
Well, look at lead number 3 and AVF and lead number 2. These are QS complexes, and that's not normal. That's not normal. Now, so that can be abnormal if you do have QS complex in 2, 3 AVF, but there is no ST elevation, nothing at all. So that can be an old inferior MI. That can be. You see
Sorry, how can you tell that?
because Q complex, QS, that's a Q wave, but too big, too deep. That's a QS.
Okay.
That's pathological. You should see a small and this kind of complex. You should see in lead number 2 another one, but you don't see this. Okay.
Right.
Now, you do see pathological Q wave, V1, V2, V3, V4. However, you know that when you do have a left bundle branch block, okay, normally you can see on the right side QS complexes. So that can be due to left bundle branch block. If you had Q wave in V6 or V5, V6 plus an ST elevation, all right, you can talk about MI as well, anterior MI, but here you cannot. It's enough if you say that could be a inferior old MI with a left bundle branch block. And we do have a P mitrale, left atrial enlargement, okay? And we do have a PVC, so the ventricular premature beat. All right?
Okay.
Good. Sebastian, the next is yours.
Yep. I have 106, I think.
110.
Oh, are we not going via the homework assignments?
There is no homework. I was written in the email that I did not give any homework. You
Okay.
had to do all of it.
No problem. Okay, so what we see here is an arrhythmic ECG.
All right.
P waves are difficult to distinguish. There's either what I would say is a lot of noise, but I think probably a little bit of like atrial flutter because of the sawtooth pattern.
Okay. If you are looking at, for example, this area,
yeah,
that could be the saw waves or flutter waves. But
exactly.
But we have to get closer, first of all.
Okay.
Okay, get closer and determine the heart rate. I mean the atrial rate. This is faster than 300, 350.
Yeah. Oh, so then AFib, it would have to be.
Exactly. And arrhythmia and the atrial rate is more than, for example, 300, 350. You should say, or you should go for the AFib. Very good. Very good. Very good.
So next, I guess I'll do heart axis. We've got positive lead 1. We have a positive AVF. So we are within the physiologically healthy range of heart axis.
Okay, good.
P waves, well, because it's AFib.
There's no P wave.
Exactly,
you don't need to talk about PPR. That's fine.
Okay. So then I guess next I look for pathological Q waves. And, well, none in lead 1, none in lead 2, none in lead 3. I don't see any.
No. In AVR you see, but AVR doesn't count. Okay, that's okay. Fine.
Okay. I guess next I'll look at the ST segments, and well, it's difficult to tell, but I think for example, if we look at V2, well, the T looks quite tall, but the ST segment itself looks
well, if you are looking at, for example, this beat, it's okay. There is no elevation, no depression. Okay, here you can see maybe a little depression, but it doesn't count. I don't think that is any ST changes can occur here. And the T wave is okay. You cannot see anything. Hypertrophy, the size of the R, I don't think that is any, because here you have 15, and in V2 this is the largest T. It's about 20 or maybe 17. It's not over 35. So there is no left ventricular hypertrophy. So only what you can see here, that's an atrial fibrillation, and the axis, what you said, this is completely it's normal. So nothing else. That's it.
Cool.
Okay.
Yep.
Good. All right. So we go. I'm going to see what is the next one. Okay. Maybe. Yes, 11. Anna. It's yours.
Okay.
Somebody's arrived, and this is maybe SOS85P. Who is this? SOS85, please say something. Who is this SOS? No, disappeared. Okay. Now, Anna, it's back to you.
So this is a rhythmic ECG,
Mm-hmm.
and there are 3.5 blocks in between R wave.
Mm-hmm. Or almost
So
4,
that's
okay.
gonna be almost 4. So that's gonna be 70, 80,
80, okay.
80 beat per minute.
All right.
I can see P wave
Mm-hmm.
with the sinus. And
Mm-hmm.
then this P wave is followed by
The
QRS.
morphology of the P wave.
Okay. So it's less than 0.25 millimeters and longer than one, no,
No, it's
shorter
not.
than
It's
1
0.1 and less than 22. Okay, so that is normal. All right.
normal. And then this is followed by QRS.
Okay.
And then between PR, it's less than 0.2 seconds as well. So it's
Mm-hmm.
normal.
Mm-hmm.
After that, it's QRS.
Yeah.
It's not wide, so it's also
Mm-hmm.
normal.
Okay, we can see.
Then
Mm-hmm.
axis.
Mm-hmm.
Well, lead 1 is negative and AVF is positive, which means it's between how many degrees? 90 to 180 degrees.
Mm-hmm. AVR
And
is a
then
little bit negative, so it's close to 120.
120,
So somewhere
yes,
here, okay. So it meaning we do have an extreme right deviation, yes, or right deviation
yeah.
at least. Okay.
What else should I say?
Next one, pathological Q waves.
It is notched on lead 2.
Lead to the pathological Q wave. Pathological. No, no, no.
There's no pathological Q waves, I
Okay,
guess.
no. Next one, go for the hypertrophies. So first of all, let's see V5, V6 is a very tall R. No. Okay?
No.
However, V1, you do see a big R wave, yes?
Yes.
Okay. And in V5, V6, if you compare the R wave to the S wave, you can see that RS ratio is less than 1. So it's meaning the S is too deep. What does it indicate if you do have a R wave in V1 and the deep S wave in V5, V6?
It's right ventricular hypertrophy?
Yes. Correct. Yes. Okay.
Okay.
Good. Very good. All right, let's move on. Let's move on. I want to find a good one. A good one. A good one. Yes. Park. I'm sorry, using your
Professor,
surname, but yes.
sorry to interrupt. Ryan was the SOS85P, but his next.
Yes, I already found it, Asif.
All right. Yeah, his Zoom is glitching, so he's having problems.
Okay, but he can use the phone or anything. That's the problem. I don't know what can we do with him.
Okay, just to let you know.
Okay, thank you very much. Okay, 115, Park. I'm sorry, I'm using your surname.
Oh, it's okay. It's okay. Uh, it looking at the rhythm strip, it is rhythmic,
Mm-hmm.
and there are three boxes approximately, the R to R, so
Mm-hmm. Mm-hmm.
around 100 beats per minute,
Mm-hmm.
tachycardic, and there are P waves present.
Yes.
Um,
Let's see the morphology of this P.
yes, I can see there is something wrong with it.
If I say so. How does it look like?
Like two waves, like double waves.
Looks like it's nudged and wide. What does it mean?
Um,
Okay, that's a normal, all right? That's a normal. That's a tall. But the duration is okay. Here the duration is longer and nudged and wider and tall. That's normal. This is P pulmonale, right atrial enlargement. This is P mitrale, left, okay? Atrial enlargement. And this is both biatrial. Okay?
yes, I'm just noting it down.
But it was on the video.
Yeah.
So we do have a left atrial enlargement, okay? Good. Next one, PR interval.
PR interval. It's less than oh no, sorry. I look lead to okay. Looking at lead to it's more than 0.2 seconds, so
What does it mean?
it's elongated,
Mm-hmm.
prolonged.
And what does it mean?
Um mm,
Hmm. What does it mean? We already had this one. Rhythmic, sinus P,
rhythmic.
PR longer, every P followed by QRS. So,
Oh yeah, I don't know.
yes, you know it. We already discussed it. Anybody?
Sorry, I couldn't hear just then. What was it, the question?
Okay. We do have rhythmic heart and PR is longer.
Oh, it's a grade 1 AV block.
Exactly. All right. Exactly. So that's the first degree AV block. All right.
Mhm.
So look, when we evaluating the P wave, okay, this is the first, we evaluating the P wave. What can we say about this P wave? First of all, the duration, okay, duration. And, well, you are seeing that in lead number 2 and AVR, right? This is direction. That's sinus or not. This is what you can say. After the shape. And another one, the rhythmicity. All right. Duration and the shape, that can give you the sign of hypertrophy. Yes?
Yes.
Okay? Whether the depolarization is good or not, so it's coming from right to left, this is the sinus. You can say that the sinus. Rhythmicity. If you do have P wave and this P comes regularly, that's a sinus. If it's not regular, you can say that if, for example, you have missing P waves, that can be two things. One, there is a impulse formation abnormality. For example, sinus arrest, okay? Or you can say that you have a sinoatrial block. Okay? This is what you can see. Next one. We are evaluating the connection between the QRS and the P wave. This is the AV conduction. Yes? This is the AV conduction.
Yes.
You can say that's a long or P is coming regularly, but not every P followed by QRS. We do have another block. Okay, that's a first degree block. That can be the second one. Or no connection, that's the third one. All right? Or sometimes yes, sometimes not. That's the high degree. Okay? And if it's short, that's the pre-excitation. That's a WPW, for example, or LGL. All right? QRS. Next one. Wide. You can have bundle branch blocks. Yes? Narrow. You still have to look at V1 and V6, because if you do have a shape changes, it can be an incomplete right or left bundle branch blocks. But if it's narrow, it's okay. You can calculate the axis, it's fine. And you can go for the very important one, pathological Q wave, yes? And the axis, I would say the axis here, okay, axis. If it's abnormal, this is a extreme right deviation or extreme left deviation at D. It should be D. All right, is D. If you have a extreme left deviation, that means left anterior hemiblock, unless you do have all those things that I mentioned, or left posterior hemiblock. Okay, and after you can go for the ST segment. Now this is how you go through the all ECGs, step by step. This is important. All right, now.
Wait, can you repeat the part of pathological Q wave? Because I kind of get stuck with that all the time.
Okay,
Do you
what
have
is
to
the
explain it?
pathological Q wave?
So does it mean like if it's narrow or wide and then
No, the pathological Q wave means that, first of all, if you're looking at those leads where you should see Q wave normally, that Q should be wide, at least 1 millimeter, and deeper than 1/3 or 1/4 of the R wave. This is one. Okay? Or you do see Q where you should not see Q, such as V2, V3, V4.
Okay.
That's it.
Okay.
Now,
So
here we mentioned that we do have an elongated PR, but every P followed by QRSs, that was first degree AV block. So far we have P mitrale, we do have a first degree AV block. Next, we have to talk about the QRS. What is the first? You have to look at how wide the QRS is. Okay? Is it wide?
yes.
Park is yours.
Sorry. Yes, it's wide.
Don't fall asleep. Okay, it's wide. What does it mean? You do have a supraventricular impulse formation with an intraventricular conduction problem. You have to look at V1 and V5, V6. Whenever you do see the nudged R wave or a wide R wave, the block is there. So what we have here?
Um,
Hmm.
do we just talk about this?
Yes,
Um,
we already had this kind of right bundle branch block. Not?
yes, I will.
And axis. Negative, right deviation, okay? Well, or let's see, because AVF is negative, both negative. So if you do have negativity, so you are somewhere here.
Mhm.
That meaning is the extreme right deviation, okay? That can be, for example, a left posterior hemiblock. Next one, pathological Q wave.
That's logic Q wave.
Hmm? You do see 2, 3 AVF, and together with you do see an ST elevation as well. So you do see a inferior STEMI, okay? All right. And inferior could come together with posterior ST depression, see? Hmm? And a very tall R wave, okay? If you are looking at this one, is the initial R is very long. That can be a pathological Q wave on the back, or that can be the right ventricle hypertrophy as well. Hmm?
Yes, noted.
Okay. All right. And if you are looking at, you still have pathological Q wave, for example, in V5, V6 as well. And that can be that you do have an infero-posterior, and that's a lateral MI. Almost everything on the CCG. All right. So step by step, you have to follow this one. Okay, Milos. Wait a minute, I have to find you a good one. Mhm. 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 It's too easy, but you can do it. Okay.
Okay. So it's rhythmic,
Mm-hmm.
heart rate 100 BPM, so tachycardia.
Mm-hmm.
Um, visible P waves. They're all followed by QRS, so no AV block. Sorry, no conduction abnormality. And morphology of the P waves.
Normal?
Yeah, but there's some changes.
What do you mean?
Actually, no, it's fine. It's fine. Sorry. And like lead 3, it looked a bit different.
Yeah,
Like
but lead 3, you are looking at lead 2, and that's it. And whether it's tall or bumpy, or that's it.
okay.
So that's okay. So that's a sinus. PR interval.
PR interval is consistent
Mm-hmm.
and normal length.
Mm-hmm.
QRS, well, for the most part, is narrow.
It's narrow.
Well, it is narrow, and it mm, seems fine.
Good. Axis.
Axis negative lead 1, positive lead AVF, and isoelectric lead 2. Is that fair? So it's extreme right axis deviation.
Okay.
Next, pathological Q waves, I guess. No pathological Q waves.
Okay.
I'm not sure. Is there an ST elevation of some kind?
I didn't say we're still in the QRS.
Maybe in large QRS, like a
The
tall.
tall R wave in V1 and the RS ratio less than 1 in V6, V5 because the S wave is too deep. It's meaning that we do have a
Hypertrophy.
right ventricular hypertrophy. And this again, the strain, what you do see here, the strain phenomenon. Okay.
Okay.
Oh boy. I want to find a good one. A good one. A good one. Yeah, we already had this one. Uh-huh. I think we haven't had that one. 113. And jumping back and forth, but this okay. All right, Sebastian.
Yep, I'm here. Okay, so what we have here is a rhythmic ECG. Heart rate, it's about slightly over 3 squares between, so it's somewhere between 75 and 100 beats per minute. Heart axis, well, lead 1 is low amplitude, but I'd say slightly positive, verging on equiphasic.
Okay.
AVF is negative, so I would say we have to be between like 0 and 30. Yes. Okay, let me see. If that's negative, then yeah, I'd say between 0 and 30. That's what I would say. Oh. So AVR.
So it's less than minus 60 because AVR is positive, mostly positive. Okay.
Oh,
Lead
okay.
number 2 means negativity means that you are somewhere here. All right.
Yeah.
And because AVR is positive, this is not negative. Negative in this area, positive in this area, AVR. So that's the extreme left deviation.
Okay.
What
All
does
right.
it mean?
Left anterior hemiblock.
Very good.
Good. Then moving on to P wave and PR. The P
Mhm.
wave, especially in lead 2, you can see is very like spiked and tall, which to me indicates, well, it's a possible indication of cor pulmonare, like right atrial hypertrophy.
Very good.
PR interval itself looks normal, so we don't have a AV block of any kind.
Excellent. Yes.
Pathological Q waves. Well, let's see. There's somewhat of a Q wave in AVR, but that doesn't count, I think you said. So we will look at the precordials. It's difficult to see with the quality. It sort of looks like V1.
I will draw you, especially in V1. We like V1 very much.
Oh, so it's an RSR there.
Oh, shoot.
By
I
the
should
looks
get a pen, but I cannot draw with a pen either. So
okay. Oh, that's interesting. Could you zoom back out, please, so I can see
yes,
lead
I
6?
will. It's narrow. The QRS is narrow. It's
Yeah.
okay. And if you are looking at, for example, lead number 1, it looks like that the second phase a little bit wider.
Yeah.
So, but it's still narrow. So all of them is narrow. That can indicate
Well,
this pattern indicates.
well, the RSR is right bundle branch block.
Okay. And because it's not wide, this is an incomplete. Okay.
Incomplete. Okay.
And this very similarly, you can be seen in the wider S wave, for example, on left side. So that can support a diagnosis that that's a right bundle branch block and a left anterior hemiblock. Together is a?
Bifascicular block.
Yeah, exactly. Exactly. Hypertrophy, if any?
Not in the ventricles, I don't think.
No, that's it. No. ST segment is okay. There is no other sign. Okay, good. All right. Not too bad. Okay. I think we had that one. We had that one for sure. Let's move a little bit further. Okay. I think we had this one, 18th. Oh, yes. Okay. That could be good. I think we haven't had 120. Yes, we haven't had it. And Anna, it's yours.
Okay. Well, this is, I can say this is rhythmic too.
Good.
The heartbeat is around less than 4 blocks. So
No,
it's
it's more than 4, less than 4, but more than 3. Yes.
more than 3, but less than 4.
Okay.
So that can be around 80,
Yeah, but
80,
you could
90.
say as before, I think maybe Sebastian said it or Miro said it, I don't know, between 75 and 100. That's it.
Okay, 75 then 100 beat per minute. P wave, I can I do see yes, P
It's a
wave, I can
large,
see
big
P
one.
wave. The morphology of the P wave, it's less than, I can't count how much properly, but I can
I
see
help you.
it.
I
Okay,
think the duration is okay. It's about 0.1.
I think so, yes.
However,
The amplitude are very tall.
okay, so what does it mean?
It's right atrial hypertrophy.
Correct?
And then PR duration is quite long, more than
Okay, very good.
4.2 seconds.
So we do have so far what we said. We do have a right atrial enlargement, okay,
Oh,
right
enlargement,
atrial
yeah.
hypertrophy, okay, this was one. After we do have a PR interval elongation, that means
The first degree AV block,
good.
because they are followed by QRS complex all the time.
Okay, is the QRS is wide?
No, it's narrow.
Okay, good. Axis?
Axis, lead one is negative, AVF is positive, so it can be left axis deviation. No, right axis deviation, I guess. 'Cause
AVR?
the
AVR is negative, so somewhere you are a little bit
120,
less than 120, okay? But you can assume that this is an extreme right
right,
deviation, okay?
yes.
Meaning,
Trifascicular,
meaning,
huh? Oh, what was it? The right,
extreme right deviation means,
um, is
okay, right deviation can be due to right ventricular
oh,
hypertrophy,
hemiblock,
left posterior
left posterior
hemiblock,
hemiblock.
WPW syndrome can cause it, okay.
Okay.
Or if you do have a lateral MI, still can cause it.
Okay.
So, okay, let's go on.
Um, what did I say after? So, oh yeah, I did say QRS.
Pathological Q wave you can go for.
I don't see anything.
No, but you do see this
Oh,
again.
um, the
This is
right
V1.
incomplete right bundle
Mm-hmm. Mm-hmm.
Is it incomplete or complete?
Yes, it's incomplete. It's not wide.
Incomplete. Okay.
Okay, so far so good.
And then I can
Let's see.
see V4 and V4, 5, 6 has a very tall, how do you say it?
R wave.
R wave. So I thought it was a left ventricular hypertrophy too.
Mm-hmm. Okay, now if you combine this,
This three is the trifascicular
particular block. That's it.
block. Okay.
Now, how did you like it?
I think it's okay. I don't know.
It's okay.
I
So I
think
couldn't impress you. That's the problem. All right.
okay.
Okay. All right. Let's see more. More. Maybe let's go another way. Mm-hmm. Mm-hmm. Okay. It's the next on park. Okay.
134. Okay. It is rhythmic,
Mm-hmm.
and there's around 2.5 boxes between the
Well,
arteries.
let's see. It's about 3 boxes. About three. Okay, three.
Around 3 boxes, so that's 100 beats per minute tachycardia.
Mm-hmm. Mm-hmm. Mm-hmm.
The presence of P waves. Um, Hard to say. No P waves?
Okay. Basically, Well, something you can see here, but let's go for the chestlets in this case if you cannot see very nice P wave. And V1 can be a good area to look at. Yes, we do have P waves, okay? Yes, we do have P waves for sure. And that you can calculate the PR as well here. Looking at the PR, it's long, okay? We do have P waves, and basically it's a regularly coming one. And 100, it's okay. And if you do see P wave, that can be a sinus tachycardia. But for sure, the P morphology is not tall in lead number 2, not bumped in lead number 2, so there's no hypertrophy. But you do see an elongation of the PR. So that indicates,
Oh, wait. Long PR.
And flat P. Okay, you can say that, yes, we do have a flat P, okay?
Yeah. Long P.
Yeah, a long PR again, that's a AV block, not?
Look. Yeah. Again.
You don't like the AV blocks. The first degree AV block, yes. Every P followed by QRS, but that's it.
Mhm.
Next one, QRS.
Look. Just a quick look.
Is it wide?
QR is wide, yes.
Mm-hmm.
Okay, what could it be?
Basically, immediately, so far I said that let's concentrate that we do have an intraventricular conduction abnormality, yes?
Interventricular. Oh,
Yes?
yes.
Looking at V1 and looking at V6, V5.
Be a bundle branch block.
Yes, it looks like there's a left bundle branch blocked, but we will get back to this picture.
Mhm.
Okay, pathological Q wave
That's not okay.
and
This
axis.
okay. Pathologic. Yeah, we'd be looking at the morphology of the Q wave then? Is it?
No, we're looking at where can you see Q wave, a deep Q wave.
Oh, so V2 would be the deep one?
V2, no, because you do see an initial R. See? An initial R. If you do see an R wave at the beginning of the QRS, this wave is an S wave. It's not a Q wave. Because only the first negative wave before the first R wave is the Q wave. We have only one Q wave only. Is not. So we don't have.
Oh, so no pathologic Q wave.
So please revise the first lesson when we were discussing the morphology of the QRSs and how you describe the QRS complexes. Negative waves can be Q wave or S wave. Every positive wave called R wave inside the QRS. The Q only the first negative wave in the QRS. So for example, here, all right, we do have a QR, yes? Here we do have a QRS, all right? Here we do have only a Q or QS complex. Here, this is a famous RSR. Yes? And here, this is an RS. Okay? Oh?
Yes. Yep.
I'm happy that you started to study. That's okay. That's good. Now, so it looks like there is no pathological Q wave. Fine, period. Go on.
Axis would be lead
Uh-huh.
one is positive.
Uh-huh.
AVF is positive. So
Okay, so you are between somewhere here.
yes.
Okay, because lead number 3 is about equiphasic. Good. So on 30. Good. Next one. STT.
Um, wait, so the large one is a
That's a T wave.
T. Oh, okay.
That's a T wave. You do have a prominent T wave. What does it indicate? Hyperkalemia.
Mm.
Now, this is another very important point of the ECG. Of course, you are not going to detect or not measuring the potassium level based on the ECG because you can send the blood sample to the lab, but it does have sign on ECG. What does hyperkalemia do? First of all, P wave, flattening, PR, widening, QRS, widening, okay, and prominent T wave. So these things, what you do see here, this is not LF bundle branch block, but this is due to hyperkalemia. If you do have a very severe hyperkalemia, you can see something like this. Almost you do see a flutter, for example, a ventricular flutter. And you have no idea which one is a QRS and which is a T wave. And if somebody has a very severe hyperkalemia, that mostly for example, the ECG gadget tries you a double of the rate that you are detecting in the puzzle. Because it will consider that this kind of complexes, this big T wave, and this is a QRS complex as well. Now, maybe I do have, wait a minute, something like this. See, this is a very severe hyperkalemia here. Look at here.
But which lead to use?
Which one is it? Which one? This is a QRS or this is a QRS? This is a T wave. Okay, I would say that's a T, that's a QRS, but it looks like as a QRS complex all the way. Okay. Interesting. Yes?
Yes.
Very much. Well. Okay. And let's see. Yum, 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 yum. Okay. Almost. No, I don't want it. Okay. All right. Let's see. 1042. Okay, 1042. And that goes to Milos. Am I right?
Yep.
Okay.
Okay.
It's your turn.
So, it's rhythmic.
Uh-huh.
We see around 80 BPM.
Okay. Yeah.
And you see P waves, and there is okay, they mostly seem normal, but there's some that have very, very small two peaks. I don't know if that's relevant or
No, it's not relevant.
okay.
Okay, wait a minute. I will draw you this picture. How does it look like? Okay. I'm going to enlarge a little bit. Okay, good. Now, 1, 2,
Mm-hmm.
3.
Mm-hmm. So the first one is the T, and then you have a abnormal
Okay,
P
that's
wave.
a T wave for sure. That's a P wave for sure. What is this?
Could it be an extra P wave?
No,
Could it be part of the P wave, but like a
no,
atrial enlargement?
That's a normal wave, but in this case, that's prominently could occur. Everybody could have this kind of wave. All right. I'm drawing this ECG pattern. Okay, this is a P. That's a QRS. That's the T. That's something. That's the P. And the QRS. P wave, T wave, P wave. Know what kind of wave can be between T and P?
I'm not sure.
Anybody?
Is that a atrial extra?
Nope, nothing to do with the atrium. This is a event ventricle happening at late repolarization of the posterior-basal area of the ventricle. That's an official terminology.
So it's a what? Sorry, it's a posterior basal ventricular depolarization or repolarization.
Repolarization, not the re.
Yeah.
A U wave?
Yes. And what the prominent U wave represents?
That hypokalemia?
Yeah. Yes. You haven't watched the videos about the ion disturbances? Am I right?
I watched the hyperkalemia one.
I watched all of them except this one. Yeah. See? That's if you do see prominent U wave, that's hypokalemia. If you do have tall T wave, hyperkalemia. Okay? Do not forget it. And in case of hypokalemia, again, you can have a widening of the QRS complex. That's fine. It's completely normal and prominent U wave. That's it. Okay. Please watch those videos.
Yes.
Ah, yes. Okay. 143. That goes to Sebastian. Yes. Oops.
Yep.
Okay.
So we have a rhythmic ECG. It is bradycardic because we have 1, 2, 3, 4, 1, 2, 3, 4, 5 squares. So, well, actually, then on about 5 squares, it's about 60 beats per minute, so not so bad. Let's see, P waves. I see P waves in lead 3. So we do have P waves. Also in AVF, I can see.
Yes, we do have P wave, and if you come here, that's a P. Okay.
Yeah.
That's a P.
So I guess we can call this a sinus rhythm then. Heart axis. Lead 1 is positive. AVF is positive. So we have a normal physiological heart axis. The PR interval, well, because the P waves are very small, it's difficult to tell, but it's pretty normal. Pathological Q waves. I don't see any because in V1 and V2 they're preceded by an R.
Okay.
The QRS is narrow. However, in leads 2, 3, AVF, and so forth, the T wave is quite high, and I would even say that in AVF and in lead 3 we have ST elevation. So I know that a high T wave can point towards hyperkalemia.
It's not the T is not high. This T is not high. This is not high.
All right. Well then, because we've got ST depressions in V2 and V3,
and V4.
And V4, I think this is indicative of ischemia in the posterior.
Okay, that's more than ischemia. That's a lesion, or you can say that's a STEMI. Okay.
Okay, so posterior STEMI then.
That's an infero-posterior STEMI, okay? Infero plus posterior, all right? That's good. And here again, we have something.
Whew.
This is
What
what
is
we discussed before.
it was the U waves.
Yes, that's a U wave and
Also,
flattening of the T wave a little bit, getting, see? And normally the T wave should be a little bit bigger than this one. And when you do have hypokalemia, you do have a flattening of the T wave. And another thing that it can be that the QT interval is getting a little bit
longer.
wider.
Yeah.
Okay. So we do have an infero-posterior STEMI. That's a hyperacute that we do have here. Or
Okay.
STEMI, you can say it. Plus,
Sure.
we do have a hypokalemia.
Okay.